Thank you, Gwen. Looking forward to starting, and welcome to everyone here. As you can see, the title of my talk is Advocating for Family and Professional Care, What Quality Care Requires of Us All. Next slide, please. So this is all taken from my book, The Soul of Care, published by Penguin a year and a half ago. Next slide. And the slide after that, so the structure of the book, which is also the structure of the talk, is putting two things together. One, a memoir. It's a memoir of my life, and particularly my care, as you heard, for my late wife, Joan, who died of early onset Alzheimer's disease. And it's structured around analysis of what is caregiving? What is it really? And why is it so important? And as you'll see on the left side of your screen is the rod of Asclepius, which is the symbol of medicine. It's a winged staff with a serpent wound around it. But I think this is the wrong symbol for medicine. The better symbol would be the caduceus of Hermes and Mercury, which is a winged staff, but with two snakes wound around it, looking at each other, interacting, and representing reciprocity. And I'm going to suggest that reciprocity is the core of what caregiving is. It's what the caregiver does, it's what the care recipient does, and it's their interaction together. Next slide. So in order to get you in the context, you have to understand that I spent my whole career studying care and caregiving. I've written a number of books on it, done lots of research with many research articles, et cetera, et cetera. But I'm bringing you now into my personal experience of care as a family caregiver. And this is me and my wife, Joan, in 1965, when we married. For those of you who are my age, it was said of Joan at Stanford at that time that Audrey Hepburn was a Joan Kleinman lookalike. Next slide. And this was the two of us during my residency in psychiatry at the Massachusetts General Hospital, and Joan's work on Chinese art. And this is Joan on the beach at Oregon and out in Oregon. Next slide. This is the two of us together in midlife. Next slide. This is a picture of Joan in midlife. Joan took care of me for 36 years, and then I took care of her for 10. Next slide. This is a picture of us in our garden in Cambridge, Massachusetts, just at the time that early onset Alzheimer's was started. This is Joan well into her early onset Alzheimer's. And this is Joan on her deathbed, when she had only one word left, and that was my name, Arthur. Next slide. And this is the gravestone for Joan at the Mount Auburn Cemetery, a magnificent park-like cemetery in Cambridge, Massachusetts. And we summed up her life with the term beauty, wisdom, goodness, above all, love. So that's the caregiving story from my perspective. And now from all the work I've done over 50 years of research, from the books I've written, from this story of caring for my late wife, what can be abstracted? What can be distilled from it? And these are the major points I want to make. First of all, that caregiving is inseparable from relationships. Whatever relationships we had before care occurs strongly influence whether care occurs, how it occurs, and what the outcome is. And in those relationships, the care recipient is crucially present. And one of the dangers in the area of Alzheimer's and dementia or end-stage illnesses is to forget about the fact that even if the care recipient is comatose, their presence is crucial in the encounter. These relationships may go on for days, weeks, months, years. In my case, it went on for 10 years. Presence, the second thing that I want to emphasize. Presence is your fullness, your being there. You know, the biblical injunction that you hear Abraham and others say in the Old Testament, here I am, when God calls them, here I am. It's that here I am. I'm here for you. I'm with you. I'm ready to accompany you in this. That presence is not just coming out of you, but is drawn out of you or not by the relationship, by your interaction with that person you're caring for. They're as important to the presence of the caregiver as anything else. And the caregiver, in the same way, draws from the care recipient their presence, as anyone who's been seriously ill and had good care can tell you. Now, one of the dangers in professional care and also in family care is that we can do care without presence. And indeed, a lot of care is done without presence. Most care in the professional domain, I can tell you, having studied it, is done without presence. It's done mechanically. It's done bureaucratically. It's done with what we call bureaucratic indifference, as if the person giving it really was just giving it. It's very hard to bring out presence. It's hard to sustain it over time. Second thing, ritual and habits. I did a piece in the Wall Street Journal a while back at the beginning of COVID, based on the book, The Soul of Care, that I wrote, indicating how I was coping with social isolation and COVID, and how much I had learned from my care of my late wife. In order to get through long-term care, you need rituals, you need habits. You need to orchestrate the day so that you get through it, so that it's a series of tasks and engagements with plenty of spontaneity, plenty of chance for change, but there's got to be a concrete structure to it. Without that, you easily get lost, you get anxious, and you begin to lose the confidence and the skill at doing care. Care is about enduring. I reject, in this particular instance, the American idea of resilience. Resilience for me is a Disney-esque Hollywood euphemism. It's too triumphal, too romantic. None of us really have resilience over time. Resilience is the idea of a rubber band, which you expand it, and then it pops back into shape. But put that rubber band out in the sun for a while, and when you expand it, it breaks as it becomes a bit brittle. That's what happens to all of us in care. We start, we pull back, we do better, we fail at things, we get better at things. It's an ongoing process of learning, adjusting, being frustrated, overcoming those frustrations, and keep going. And the real issue is not resilience in the idea that we're going to get through this and be better at the end. It's how do we endure serious care for end-of-life conditions, for threatening illnesses, for life-threatening illnesses, for dementia, for all those problems is about how do we endure? How do we get through it? And I can tell you that having spent my career studying this, that all the evidence is it's extremely difficult to do this, but we do it. And why do we do it? Because it's there to do. When you ask most people, why did you go through and do what you did? It was so taxing, so difficult. Why did you do that? Usually they'll say, it was there to do, it had to be done. I was there, I did it. It's not something that really you prepare yourself for. It's not something that you're waiting to celebrate. It's something that you do. You do it and it becomes part of your life, a lived experience. So I don't like the term so much burden. Yes, care is a big burden, financially, socially, psychologically, but care is much more than a burden. It's a way of being in the world. You become a caregiver by doing the acts of care. Care is also a human developmental process. In our society, at least in the past, boys and girls were socialized differently in this regard. Doesn't mean that women were better prepared for care. They had to struggle with it also. But boys were raised in the 40s, 50s, 60s, 70s, changing in the 80s and 90s, were raised as to be careless. Young girls to be careful. We can think about all the reasons that that involves. But over time, this changes as men become to understand that they too must and can participate in care. One of the problems with care in our society is that men don't participate nearly as much as they should. If you go to Australia, you'll see young men pushing baby carriages all over the place in their excellent coffee shops. And the reason for that is they can get compensated for care. If we had compensation for care in the United States, as we may have if the Infrastructure Act goes through, if Biden's plan goes through, you'll see many more men contributing to care. Women don't contribute to care to this for a biological reason. They themselves have their commitments, the desire to get things done, the fact it's there to do, and they're the person often who's left doing it, in spite of the fact that women may be working professionally just as hard as men do. And in COVID, we've seen the result of this, with millions of women dropping out of the workforce because they were the only one who did the care. Now, if we look at professional care, it's impressive to see that at the lower echelons of professional care, care is done by immigrant women of color for whom it's the only available job, usually. That is, this is a backbreaking job in a nursing home or a hospital. It is low status and poorly paying. And it has tremendous turnover because as soon as women get a chance to get a better job, not surprisingly, they take a better job. So one of the real issues here that to come down on is the importance of resources, providing resources for caregiving. First of all, women in families and men should be compensated for care. That free care keeps our system afloat. If 10% of the American elderly were not cared for on their own or at home with family and friends, they would overwhelm all institutions in the United States. We've got to recognize that and support care at home, and that means giving supporting funds to family members who are providing the care. And secondly, we've got to do a much better job of the professional level of care in nursing homes and hospitals. Why has there been so much death with COVID in nursing homes at the beginning of COVID pandemic? Because of poor care in the nursing homes, almost an absence of infection control. And that's because we put so little into the training and support of health aides in that setting. Home health aid. I couldn't possibly have taken care of my wife for 10 years if it wasn't for the fact I had a fabulous home health aide. I could afford that, both because of my personal resources and because I had long-term care insurance. Most Americans do not have long-term care insurance. Insurance companies don't want to write it. It's too expensive, but it's critical. If we were Japanese, if we were Norwegians, if we were Finns, we would have long-term care insurance written into our healthcare system. We'll get to barriers of care. We'll get to caring for memories in a little bit. Next slide. Now, these are the core tasks of caregiving. This is a picture taken by a former student of mine who's a young professor, University of Massachusetts, Felicity Alino, on her own work in caregiving in Thailand. And here you see a daughter with an elderly mother, the daughter providing a massage, support. Care begins both in the professional and family setting with acknowledgement and affirmation of that person deserving respectful care. That's the ethical core of care. And that should happen in medical settings with doctors and nurses, but it's happening less and less because of the craziness of the electronic health record. Doctors are trying in a frustrated way to make sense of the screen, and often the doctor-patient interview starts today with the physician's back to the patient, which doesn't allow for acknowledgement or affirmation. Care, the work of care is what makes you a caregiver. Doing the work of care, not talking about it like I am now. I did all these things: feeding, bathing, ambulating, toileting, protecting, all the things that have to be done to get that person who means something to you through the day. Care is also about emotional support. And it's about moral solidarity, the sense that I'm going to be there with you and for you no matter what happens. I talked about the other issues. Let's get the next slide. Thank you. And this is my point about care and caring as human development. And the only thing I would add to this is that over time, as people age, lived expressions of these gender differences become less pronounced. And you begin to see amongst men, for example, a more mature, engendering nature emerge, which is part of becoming better at doing care. Next slide. Now, the challenges of caregiving, there are tremendous challenges to caregiving in our time. There's a crisis in long-term care funding. Our long-term care health part of the healthcare system is completely broken. I can tell you, completely broken. And the best sign of this is what's happened under COVID. The failure of our long-term care system is the 70% of the COVID deaths occurring amongst the elderly. Increasing numbers of people are entering the workforce, so there's no one at home sometimes to do the care. The challenge to values of family caregiving in a neoliberal age, which is the age that we live in, with its tremendous emphasis on individualism and individual consumption, you got to step back from that and see care as an important part of what life is about. The hyper-individualist myth of our society that we all pulled ourselves up by our own bootstraps, that no one helped us, is completely that, a myth. We've all been helped. We've all had care given to us. Not just care for illness, mentoring is a form of care as well, bringing people along in professions and at work, etc. Sometimes there's kind of a courtesy stigma that comes from the person who is sick and receiving the care recipient. That stigma goes from the care recipient to the caregiver. And you see stigma associated with stigmatized conditions. Then there are huge now gaps in knowledge and communication. And this is true in families and it's true professionally. I'll give you the best example of this is a report by the National Academy of Medicine a few years ago called Families Caring for an Aging America, which showed that it was commonplace for elderly who had had surgery to leave the hospital, go home, and no one had informed the family about how to take care of the elderly. So if you've had a gallbladder procedure or serious surgery on the abdomen, you might come out of the hospital with 1 or 2 drains coming from the abdomen. Family has no idea how to take care of this, scared stiff that they'll infect the person. Just a total failure in communicating to family carers. Some people believe that this has to do with HIPAA rules, but in fact, HIPAA rules allow for serious communication with families. It's a misunderstanding of what HIPAA is about. And on the professional time side, just no incentives and little time given to really interacting with patients in an effective way, explaining things carefully, responding to patient needs. The electronic medical record is a total failure for caregiving, a total failure. It has one use today. It improves billing. That's what it does. Otherwise, it has distracted the doctors. It has been difficult to work with. It is very promising, but none of the promises have been realized. And then there are weak incentives, because all the incentives are to get the patient out of the clinic or the hospital as quickly as possible with as little use of the doctor's time as there can be. Now, here's something you may not know, and I'm telling you this now as a researcher. We have no measures of the quality of care. When you hear a hospital or a clinic say that they have high quality care, all that they mean is that they've substituted institutional efficiency, the measure of how many patients with X condition get through the hospital in Y hours or Y days. That's the measurement. What you would need to measure in care is the time spent with the caregiver and the care recipient, doctor, nurse, and patient in the hospital, family members, the quality of that interpersonal relationship, the kind of communication that takes place, the effectiveness of listening, explaining, and following up, the quality of the physical exam, et cetera, and history taking. We don't do any of those things. And as a result, we have a failure, really, of measuring quality. And what can be done? Very straightforwardly, we can provide long-term care insurance, improve a long-term healthcare system, compensate family care, improve cognitive and social supports for families. We can strengthen the moral training of professional caregivers, improve training in the core giving skills, incentivize caregiving, and complement the economic language which dominates care today with a caregiving language for policies and programs. This is really crucial. If we simply use an economic language for policy, we're lost, okay? Because care is time consuming, it's expensive. Really good care is expensive. We spend 12 minutes in a follow-up interview between doctor and patient for serious conditions like diabetes, heart disease, cancer, okay? That's what fits into our system in terms of breaking even or making money. That's not going to provide good care. 12 minutes for a complex case cannot provide good care. So what we need is a moral movement for care in American society. And I hope that your organization will play a central role in this. We need recognition of the anti-care biases of our times. This was particularly true under the last administration, but is still present today. We need advocacy and community work to generate this moral movement. Why do I call it moral? Because we have to recognize this is one of the things most at stake for us. What makes us human? What keeps us together? What is the social glue of society? It's care. We need legal and policy interventions to support family care and social care along the lines that I've mentioned. We need recommendations also for the professional side, hospitals, doctors, nurses. We need changes in medical education. We now have a terrible result of medical education. Fourth-year medical students in about 8 studies are shown to be worse than first-year medical students in empathy and in their social skills at giving care. Fourth-year medical students. They spend 4 years in medical school. They get worse at caregiving, okay? There's something toxic in the way we train doctors and also nurses. That's got to be improved. We've got to change our healthcare systems to focus on care, measure it, improve it, focus on it. And respond to burnout. More than 50% of doctors in our society have the symptoms of burnout. And you look carefully at what their burnout is. It's alienation from their work. They expected to be closer in their contact with patients. They expected to have more meaningful engagements, and the whole system prevents them from doing that. That's about half of what burnout is about. Next slide. This is my last slide, and it gets to a crucial point. Aristotle said in his Great Ethics, moral excellence comes about as a result of habit. Habit. He didn't say we inherited it. He didn't say some are good and some are bad at it. He said you make it a habit. We become just by doing just acts, temperate by doing temperate acts, brave by doing brave acts. And I would add to that, we become caring and caregiving by doing acts of care and caregiving. That's what care is about. It's not talking about it, it's doing it, but it can be done in multiple ways. It can be done in the doctor-patient relationship, in the family-patient relationship, family member relationship, and it can be done at the policy table, in the courtroom, in the halls of Congress. By doing it, by insisting that care is crucial to our lives, needs the financial support, the legal framework, and the recognition it deserves. Thank you very much. I'm open to questions.
Thank you so much, Dr. Kleinman, for that awesome presentation. There is so much dialogue happening in this chat. I'm trying to go through and see the questions. I know I saw one earlier. Yes, I see.
Question.
Yes, I just found yours, Nancy.
Sorry, Dr. Kleinman, that was awesome. I thank you so much for sharing your experience, your knowledge, everything. Is there any way I can follow you somewhere to keep learning from you?
You know, if you, I think the best place to start is to start with my book, The Soul of Care.
Yeah, I just ordered it.
I've really tried in The Soul of Care to lay out all the issues, and there's even a little section on policy, although I'm not the key person on policy. But if you look at for example, the policies being put forth today by people like Slaughter or the latest wave of feminists, I think they have some great ideas. They have great ideas about what needs to be supported, okay? Becoming involved with care has made me a feminist. Right? I think that recognizing the incredible contribution of women, and it is an incredible contribution of women, in our age especially, where women are both professionals and caregivers. I think it's just an extraordinary contribution. Men have got to step up to the plate. They've got to contribute as well. And women need the financial and social supports that will make caregiving more effective. So want to follow me, start with the book and take it from there.
Perfect. Thank you so much, Nancy. And we have an awesome question and comment in the chat by Nicole. And she wrote, we often approach caregiving by trying to make things better and fixing ailments a patient may be facing. Your point about presence hits home hard because it was likely the best type of support I could have given my dad in his final months. Do you have any advice for how to best be present for your loved one and to fight the urge to fix things?
Yeah, well, first of all, that you've had the real experience, so I can just hear it in the question. Thank you for that really telling question. I think the big issue is how do you keep presence going? I'm sure taking care of your dad, like when I was taking care of my late wife, takes an awful lot out of you. And at times you really want to run away from it, or you feel, you know, I'm not doing the job I need to do. It's keeping going. That's the answer here. Sometimes, yes, you'll see that you're trying to fix things that can't be fixed, that you have a kind of a savior's complex. Absolutely, you're going to get over that. But more important than that, I think, is just keeping going, keeping the humanness going, not becoming mechanical, not becoming bureaucratic, not giving in to one's frustration and anger, because you become frustrated and angry at yourself in care, because we fail so frequently. Care is not about dunking the ball. It's the fact that you're going to fail. You're going to make mistakes. You're going to realize, I should have done that better. I could have done that differently. Well, you get a chance in care to go back and do it better, do it differently. I think that the key is not to be afraid of care, not to be afraid of care. It's there to do, you step into it. And in the course of a marriage, for example, care has been reciprocated over decades by a married couple, going back and forth. For me, my wife took care of me for 36 years. Okay? I took care of her for 10 years. That was part of the bargain, part of the deal, part of the vows, part of our relationship. And we went through it as a team. To the extent it's possible to do that, to be a team, care recipient and caregiver together, you get much better results, I think. And you feel better about doing it. We know some important things. That care is burdensome, so that caregivers who've been taking care of patients, let's say patients with dementia for years or a decade, as I had, have higher rates of stress and of illnesses. But you know what? They live longer and feel that their lives are more purposeful. That's not a bad outcome from doing care.
Much. That was really helpful.
Yes, thank you so much. And we have one last question from Caitlin. I know that oppositional response to the idea of supporting daycare has been that it's a government takeover of parenting and curricula. And I'm sure that it will be similar to the proposals adding to our caregiving infrastructure. How do you respond to that, Dr. Kleinman?
I respond to that by saying that you've got a government that's supposed to be doing something. Here's what life is about. Life is about care. Put the money into it. You want infrastructure? No more fundamental infrastructure than caregiving in life. As important, if not more important, than bridges, roads, streets, highways, okay, trains, planes. Caregiving is critical to our lives. And if you see it amongst people who have the least resources, you realize they need resources. Poor people, they need resources to do care. They don't have any. It's astonishing to me, in the course of my career, I've worked with many people from poor, marginal, often communities facing racism, amongst other problems. What's astonished me is the quality of care they give in spite of the resources. Imagine what they could do if they had the resources. And that's true of home health aides and of aides in nursing homes. These are poor women of color who have no alternative jobs. They need the training, they need the support, they need the opportunity to grow at work. And they do usually a great job. It's astonishing, under the pressures they're under, how they do what they do. Okay? So I'd say it's a joke to think that our government pushes all of this on the families, on individuals. All other sophisticated societies in the world, their governments put money into caregiving. Our government has got to do the same thing. Thank you very much. It was a pleasure to be with you.